So in the history, you asked, okay, history of presenting illness, we have to describe the attack, how exactly it happens. Suddenly she falls down, and but she can remember about what was happening with her. She sees to it that she will not injure herself. And all these things was asked, and any triggers was also asked in the history. And in the year what I go, all these complaints were also asked. The triggers I told clearly: fear, and also any bad event seen, or the physical activity sometimes. I think history she covered okay, not bad. In the social history, mainly school performance was covered. In the presentation, I don't know why she added sounds. I did not tell that the child fainted anytime for the sound, right?
No, there's some, you said some toys are there in the house, and then they make
Toys, I told she will see the toy, like the lizard or something. If it is thrown to her, if it is near her or thrown to her, she will faint. Not like she has. I did not tell you the complete story. Just I told you like this. She has two boys, two brothers. They sometimes tease her with the toys. This is the thing. But there is no sound, huh? So just be careful.
Okay. Yeah, okay.
I did not tell about the sounds. Okay, this is what is the additional thing you added, but otherwise you told fine. I took history from Mrs. Jessica, the mother of Mary, 11 years old girl, who presented with sudden attack of fainting from 10 months, increased in frequency from 3 months. But what you did not tell here is the time. You can, the history of present illness, better to tell everything in and out, because this is the main history he will be expecting, the lasting time, and there's no post-ictal phase. These 2 points I think you did not mention in the summary. It lasts only for 1 or 2 seconds, and there is no post-ictal phase for this. The child is active. Or you can
sorry
just
to interrupt.
huh?
Sorry to interrupt, Dr. Fatima. We will not say post-ictal phase. We can say,
Or you can just say she's responsive immediately after the attack.
Yes.
Yeah. Sorry. Yeah. Even I agree with you. We can. You have to mention these 2 points. The time lost, because it's just transient. Sometimes fraction of seconds, sometimes 1 second, that's it, or 2 seconds, and immediately she will respond to you. She may sit and relax for some time, but she's responding to you. She's in full response, not like in the seizure case where there will be no response at all, right? So this too you did not mention.
Okay.
And did you tell the important negative in the history? I agree with you. You commented on the family. Family, nothing was there, because I said no fits, no sudden deaths. And this was a good question by you. This is very important in this history. No sudden death in the family, and even the fits, to rule out the neurological causes. And social history covered. But did you mention the important negatives in the summary?
No, I don't think I said negative family history. I should have mentioned.
After family and social, you should mention the important negatives.
Okay.
Like again, to rule out the neurological causes, she has no complaints of the heart, like as already you asked that, and the mother also told that the GP told her heartbeat is fine and he did not see anything in the heart. From the history, whatever you got, she has no complaints from her heart side, and no early morning headache or vomiting, or any neurological symptoms suggesting a neurological cause. Like this you can tell to the examiner. This is my, but I want others also to put their summaries, so that we will improve the words. We have to play with the words in the summary. Okay.
Psychological aspect she covered, like school bullying or any financial
covered,
support.
yes.
Family.
She asked bullying. I wrote
financial.
Yeah,
and financial stuff.
She asked bullying, she asked financial, she asked about our jobs, She did everything. 1 minute.
Dr. Fatma, can I interrupt?
1 minute. I will just finish off because I have written here what she missed, which I catch. Then I will give you the option. Then good differential diagnosis. Better always let us give at least 3 differential diagnoses. The top one will be the most probable. The second one most likely, means maybe. The second one is maybe you can take it, and the third one is the least likely. Let's prioritize like this. With this history, yeah, exercise history is very important, which she asked, and I told her only once. If it was aortic stenosis or something and she's playing a lot, I told her, and with this repeated playing, she would have had multiple attacks during the exercise, right, for aortic stenosis. But here it was only once after the exercise. So most probably going with the vasovagal. So her topmost is the vasovagal, which is good. And next is the cardiac causes. She said syncope, she has to rule out from the cardiac causes, for which she will be doing an ECG next. And then the seizure disorders, maybe it's least likely. Then in the bedside, you will tell the BP, which she told sitting and standing. I think we have to also include lying. Any comments on this? All the 3, or lying and standing is most better than sitting and standing?
Sitting and lying. Sitting and
Sitting and
lying.
lying, we should ask whether the GP has done this, in both the positions.
No, this was not commented in this. Okay, she can ask. But the mother said he only checked her heart and did the investigations. She did not comment. So she can tell, you can check again. It is nothing there. But my question is it sitting and standing, or lying and standing, or all the 3?
Sitting
I-
and lying.
I read this one, this BP difference of 10 millimeters of mercury, I didn't know. Today, while preparing in the evening, I'll share that article with you. It is one of those NHS things only. If there is any other information which is from any of the guidelines or any of these NHS websites, please share it in the group. But
Even
this
I
had
read this yesterday, what you are telling, there is a difference of more than 10 millimeters in the sitting. I think from the guidelines, it is sitting and lying, but we will confirm again, okay? More than,
Yeah.
sorry, it's not sitting and lying, sorry, standing and lying. This is what is in my mind.
Standing and lying.
I read somewhere
Standing and lying.
standing and lying, not the sitting one.
And for
Yes.
this, for this, we have a test called tilt-table test.
I was about
So
to
whether
ask
that
you,
is, yeah, you did
Can we
not
do
mention
it
in
like-
investigation. Very
No, I-
important for.
No. I read about this tilt table test. This was a doubt that I wanted to pose to Dr. Noor, that can we do a tilt table test in a young child? This is done in older people. Do we do it in young children?
No, we should go according
I
to the
don't think-
guideline. Like you said, like you read in the guidelines. That's
this is another-
that's it. Yeah.
so-
We should go with the guidelines.
No, then I think we should just again we should go back and refer if tilt table test is done in small children.
It's
This
the
was a
same
definite-
thing,
will
na?
check.
Is the same thing, the measurement of the BP in lying and standing position. If we
No,
do
tilt table-
manually, there, yeah, this is the same thing, like doing the.
No. Tilt
Okay,
table
let's
test and
check
sitting-
about this tilt test and come back, because I just read it superficially. I did not went into depth. But this I remember BP is standing and lying, and the difference is more than 10 or 20. Again, I am some confusion. I read, I did not read it clearly. We'll give you the difference, and it is, I think, orthostatic hypotension or something.
Hypotension.
Yeah,
Yes.
orthostatic.
tilt table test I read in that reflex anoxic seizures. They had written two. This one was I forgot the name of that one. Loop recording, and one was tilt table test. Tilt table test. They will strap the person on a bed, and they will tilt. The test lasts for about 45 minutes, and they will do that test in all different directions. And by the end of the test, patients usually feel tired, but exactly whether it's done in small children, that we have to go back and record.
Okay,
I didn't
we will
read that in.
we will read it. Actually, somewhere in 2-3 places, even I came across it. So sitting and lying, we will confirm it again. Sorry, standing and lying. Sitting is not there. This is my doubt. And despite all these things, still you have to do bedside fundoscopy. I feel you have to go for a fundoscopy even in this child. Any comments for this?
Yeah, I think we should do. I missed.
You have to do BP and fundoscopy. See, for all the CNS cases, still
Yes, yes,
migraine,
yes, yes, yes.
tension, headache, what is yesterday what we did, seizure, and till now whatever we did for all along with BP, don't forget fundoscopy.
Also,
She did not tell this. This is
yeah.
and GP has done the please take
Doc,
care of your mics and making all. If the GP has done the CBC, you can tell if it is most recent. You can tell that it is already done by the GP and anemia is ruled out. Just in one sentence, you can tell CBC is already done by the GP and anemia is ruled out. You would like to do blood glucose ECG, which is very good. In ECG, what do you want to check, Dr. Fatma?
Check the QT prolongation.
Yes. QT prolongation,
QT
and
prolongation
sometimes any arrhythmias also, or delta waves also in cases of SVT. Something you will get some clues like QT prolongation. And yes, in cases of children who are prone for SVT, you can see delta wave in the ECG, right?
and WPW delta type A.
Yeah.
Yeah, and I want to. You said like for this reflex anoxic seizure, this tilt table test is indicated.
No.
Or like
no. There is one star. I'll share that up. It's
Hello?
not indicated.
Yes.
Wait. Just wait. Please, all of you
Can-
write your questions. I will forget otherwise. I will just finish off mine. I have only 2 minutes left for her. You missed the electrolytes. You have to tell the electrolytes in the. Okay.
Yes, but
you can write?
particularly magnesium.
A CBC already done by the GP. Blood glucose is important because hypoglycemia can cause fainting attack. ECG is important for prolonged QT and any delta waves or any arrhythmias or anything you see which will give you a clue of some heart problems. Like in aortic stenosis, you may have ventricular hypertrophy, something like this. No need to tell ECG. If he asks, you can tell. This is just for our discussion. We will just tell ECG. If he asks you something, what do you want to check in ECG? At the time, you can give some 2-3 points like this QT prolongation or delta waves for SVT or any arrhythmias which can be given clue, or any hypertrophy which can give us a clue of the hypertrophic cardiomyopathy and aortic stenosis, the ventricular hypertrophy. Okay, these things for the ECG.
Okay, Doctor, can I add?
Okay, tell me what.
In EEG, if you are doubting about the tilt table testing, it is yes done in children. It is one of the assessment of the syncopal attack in
So
children.
did you read anywhere, Ola? You can share for us. It's better.
Yes, it's written. I'll share it for you.
Okay, sure.
Hello.
This one is written clearly and up to date, but I will see if one
But
of
I
the
don't know
UK
up to
sources
date will work
I'll
here
send it
or
to you.
not.
Yes, I will send it from UK sources.
Ola, can you repeat that point which you said? Because
The tilt table testing we are doing for children, not only for adults.
Okay, good.
Okay.
Good. Thanks a lot.
what about
She will send
Holter?
us the picture of that, where she found out.
What about
They
Holter
are doing
monitoring?
actually this test. They are doing this tilt table test for children, and they are doing at 30 and 60 degrees of at the level of the table in different directions.
Okay.
Actually, it is not recommended to offer a tilt test to people who have a diagnosis of vasovagal syncope on the initial assessment.
Yeah, then there is no need. If you are in doubt that we are not sure about that, then you can go for that.
Only if there is a recurrent episode, we are strongly suspecting vasovagal syncope, which is affecting the life, or there is a high risk of injury. Then only tilt test is recommended. And regarding the orthostatic hypotension, we need to take a blood pressure in the lying and standing position. So for standing position, we need to the person has to be there for 3 minutes and then need to check the blood pressure.
Yes.
So lying and then standing for 3 minutes and then check the blood pressure.
Yes.
I shared the guideline.
Okay.
Okay. So lying and standing. Can you repeat
What
about
about Holter monitoring?
Now, what's the difference between lying and standing blood pressure? 10 or more than 10, 20?
20.
I remember, I think it's 20, not 10.
Yes.
And one thing more in history, a very important history, it has been left is benign paroxysmal vertigo.
So what will you ask in this?
She asked in the history.
She tried.
She asked about the vertigo. I wrote here. She asked any ear complaints, any sounds in the ears she's hearing. I said no. She asked this. Regarding Dr. Fatma, I was completing my things. The electrolytes are important in this patient, right?
Yeah, I missed. I should have told.
Yeah, you should tell that. And EEG, you will strongly tell when your topmost diagnosis here is vasovagal, and it is clear for you that there is a trigger of the fear, and there is trigger from seeing something like injection, and after physical activity, that too only once, despite doing so much of physical activity. Okay, your topmost is vasovagal. Be strong. Tell no EEG. I don't want to do EEG at this moment. You can tell when you have given the topmost as vasovagal. Be clear. Then if they dig you too much, asking too many, at that time you can say, okay, I will have a consultation with but they will not do if in the clear cases, I believe. So just say EEG not needed, and MRI also not needed, because you're not seeing any. You can tell that I don't see any red flags in the history suggesting of increased intracranial hypertension or any neurological deficit, which is suggesting maybe from the space occupying lesion or the seizure disorder or anything to go for this, right?
Okay. This is definitely a blind spot, because this is what I thought I had said, but maybe I came across as not being very strong on that. I said that that is something that I would keep in my mind for later investigation, but at the moment I will not go in for an EEG. If in the future, if there is any other episodes, or if there is the history is unclear, or there is something which is favoring a seizure disorder, at that point, after discussing with my consultant, I'll go for an EEG. But anyway, I think instead of I think I'll stick to what you said.
No,
in this case, it is.
Yeah, you just tell no need of EEG at this time. No need of EEG and MRI. But if they ask you too many questions at that time, you can just tell it will not be just my decision. I will involve my consultant to take the decision like this. Obviously, we are. This is the registrar level examination. In everything, you will bring your consultant, right? Yesterday also, I told in seizure disorder, you will tell that you will start anti-epileptic medication to this child, but under the supervision of your consultant. Treatment, you told avoid triggers, but at the same time, you have to educate the child.
Okay.
Right? Education sometimes, and ask the mother to keep the diary. Please don't forget the diary in everything. From the first history we are doing, yes, for migraine also the mother should keep the diary to see the timings, and also for the triggers, for the sleep deprivations, when is he getting, what is the common time, then the tension headache also during the weekdays, what is stressing him. If she will not keep the diary, like what time he sleeps, what time he wakes up, how much screen time he is spending, and what is he doing, she will not come to know the reason of her tension headache, right? In the same way here also, to avoid the triggers, she should also keep the diary to see what is playing now, because now it is increased 4 times per month, right? So mention about the diary and education. Educating the child, educating the mother regarding the condition, so that how to avoid the triggers. And there are some maneuvers, it's mentioned in update, like crossing the legs. Okay. Doing something which will increase the venous return to the heart. This is one thing. And after the attack, you can also give her some snacks and water or some juice like this. It's written in up to date, but not here in the UK, I don't know. You can.
It is written briefly in the patient info. So education need. Yes, it's written briefly in NHS. I read it. I summarize it. So first of all, we'll give education, reassurance. And if it is attack happen or she feel that it will happen, she should lie down with legs raised up. But if cannot, this situation is not suitable, she will sit with head lower between knees. And after that, as you mentioned, to need to keep good hydration, drink some water and eat something, and take a deep breath. And this one in NHS. In what's written in the up to date, need to increase the oral intake of water at least 30 to 50 ml per kg per day. They're giving more details. Add salt snacks, avoid caffeinated beverages. And the techniques to be done to prevent venous pooling, including keep knees slightly bent when standing for a long time, as well as isometric contraction of the extremities, the muscle to raise, folding arms, and the crossing of the legs.
Okay. So I will repeat what Dr. Ola said. I wrote it down first so that for our revision. She said if it is comfortable for us, means you are at the home and there is a bed, you can lie down with legs raised up, raising up the position. This is one of the thing. Or the another option is sit with the head in between the knees, right? Right, Dr. Ola? Sit with head in between the knees. And then eat something. Actually in up to date it's given some salty snacks with the fluids, okay, and deep breathing. This is what she said. Education, reassurance, never forget. Keeping a symptom diary, also never forget to see how well you can avoid the triggers for her. Like the brothers, if they are troubling her by showing something which makes her fear, you have to control them also. So all those things, avoid triggers, education, reassurance, crossing the legs or making any maneuver which will increase the venous return to the heart. Next, Dr. Fatma, can you tell me about this loosen collar you are telling?
No, if sometimes if the child is wearing tight clothing, then you loosen the collar. So whatever I had read was avoid long standing.
The pressure on the carotid, you mean?
Yeah. Loosen the collar, squat, sit down immediately if you feel dizzy. Then deep breathing. Then educate the child, obviously, which you said. Record the event if you can.
Record.
Keep a diary.
Very important.
Keep a diary.
Keep a diary, please. All of us, let us make it common. If for many conditions you will keep diary, okay, to see what is happening with the child. So just 1 minute. Others, anyone wrote down any comments, can go ahead still if there is anything.
Can be a question, what's the indication of hospital admission? So are you going to admit all cases of syncope?
Yeah, Fatma will answer.
Any history which suggests of space occupying lesion requires admission. Any high index of suspicion of space occupying lesion. Any loss of consciousness which lasts for more than 1 minute. Probably while playing, the child had syncope and is not responding, and the child is brought in emergency. Probably that child will require admission for further evaluation. If any cardiac arrhythmias should not be missed. Then vasovagal syncope is not an indication. So these are the only two indications that I can think of. If there's any,
yes, what you mentioned is logical. It's also of orthostatic hypotension with continuous postural syncope that doesn't resolve with the fluid therapy.
With what therapy?
Fluid therapy. So if there is continuous postural syncope, and it's not controlled with the fluid therapy, and if there is persist neurological findings, as you mentioned, there is some signs and symptoms of increasing intracranial pressure, as well as evidence of cardiovascular disease like congestive heart failure, arrhythmia, or heart block.
Okay.
Okay, I think this meeting will end in 5 minutes. I will end and we will rejoin. Just we will go through some of the things from the guidelines and the patient info if possible. Okay.
Yes. I'll pray and join.